Hello, it's Mike Putman with Room Now, reporting live from ACR 2022. I am very excited to be discussing Abstract 1677, which is a plenary session tomorrow with its author, Max Konig. Would you like to introduce yourself?
Happy to, Mike. My name is Max Konig. I'm an assistant professor of medicine at Johns Hopkins.
Well, I am very excited about this abstract for a couple of reasons. The first being that I feel like it has great potential, and the second being that I think many of us don't know anything about how CAR T works. So this looked into the use of CAR T in antiphospholipid antibody syndrome. It's been an exciting area for us lately in the wake of this recently published study in Nature Medicine about lupus. But there are some specifics to the study that you did that I thought were particularly exciting. So for starters, though, would you like to give us a primer on what CAR T is?
Absolutely. And I'm going to make it a little bit more complicated by introducing another concept, because there are slight variations. But the important thing is that all of these cellular therapies that we're talking about are basically engineered T cells. In the current state, these are used in cancer immunotherapy, typically for treating B-cell cancers. We have about 6 FDA-approved products at the moment, all used for cancer indications, none of them for rheumatic disease. But obviously, as we heard over this conference, there's a lot of clinical, preclinical noise in this area, and a very exciting thing. So when we talk about cellular therapies, we're really thinking about engineering a T cell. So generally, we take autologous T cells from a patient, so they are apheresed, and then you engineer in multiple different ways. For CAR T cells, you would use some mechanism to introduce a new genetic segment that encodes for a CAR, which is a chimeric antigen receptor, which then has the ability to bind to a specific target that you're going after. Typically in the moment, this is CD19 or another B-cell marker. Now, that would do pretty much equivalent things that B-cell depleting antibodies do, but in a more potent way. Now, I'm going to make it a little bit more complicated by saying there are more than one way to engineer a T cell. So in our case, we were interested to think about where could these therapies go in the next 10 years. And we're particularly interested in figuring out if there are ways that we can engineer the T cell to not only deplete all B cells, but really just go after the autoreactive B cells that cause the disease and leaving the 97 to 95% of B cells that are normal and protect us untouched. So we're doing this actually by not engineering or introducing a CAR, but by engineering the T cell receptor directly. So what we're calling the therapy that we're working on is actually a CATCR, a chimeric Autoantigen-TCR, T cell receptor.
I like that. You need a good name for something if it's going to stick.
It needs to be catchy.
No, but I also truly like the concept. I think that I am maybe inappropriately skeptical of the lupus data because I also think that we already have B-cell depleting agents. But the idea of targeting a specific subset of B cells sounds truly revolutionary to me in a way that I hadn't anticipated. So why don't you tell us a little bit about what you did in this particular study and how that fits in?
Absolutely. So this is more of a proof of concept in the preclinical space at the moment. So we're basically figuring out whether something as specific as we hope to do can actually be done. So the hypothesis is that we can take somebody's T cells and engineer them in a way that they could really go after a specific subset of B cells. So in the case that we first applied this, we're going after antiphospholipid syndrome specifically because we know that there are pathogenic antibodies that target beta-2 glycoprotein, specifically domain 1. And if you inject those into a mouse, the mouse develops APS. So it's pretty straightforward. And if you block it, the mouse doesn't develop APS. So, if you were able to go after that subset of B cells, it has a lot of potential to potentially, deplete that subset of B cells, but prevent the common complications that we have with B-cell depleting antibodies and probably also with CAR T-cell therapies, which is infection, no vaccine responses, decreased antitumor immunity.
I want to dwell on that briefly because that was another reason that I was somewhat skeptical of CAR T is that the risk of somewhat serious immune reconstitution syndromes and sort of hyperinflammatory states it was relatively high, somewhere around 10 or more %. So this particular approach that you're doing, you think may have less of that. Can you explain why? Because I think it is actually quite tangible and it makes a lot of sense.
Right. And to be fair, there's not a lot of data at the moment, so this is mostly speculative and like extrapolating a little bit from the cancer literature, where we know that if you target patients who have a B-cell cancer, but the cancer is in remission or fully depleted, they have less cytotoxicity, like less CRS, less side effects. It's not perfect, but that's the trend. Now, it really comes down to, I think, the amount of target cells that you're going after. So in cancer, your whole body is basically cancerous B cells. So the burden of target cell is high, so you have a lot of T cell activation, a lot of immune side effects. If you compare that to autoimmunity, where we typically have a very normal number of T cells in general, and B cells in general, you can imagine that in that setting, the fraction of B cells that you're really trying to deplete is low, right?
Very small.
And even just having regular B cell depleting all B cells is still a relatively small burden of B cell number compared to somebody with cancer. So I think there's a correlation between the number of target cells and the number of T cell activation and the number of immune side effects.
Makes a lot of sense. So in your study, how successful were you at targeting these specific B cells in this preclinical study?
Right. So I want to say we're early, right? This is proof of concept. But we will be able to show that by engineering the T cell receptor directly, by introducing autoantigen into the T cell receptor, in this case beta-2 glycoprotein 1, we're able to take away the native reactivity of the T cell receptor and replaces with a new ability to bind specifically the anti-beta-2 glycoprotein D1 specific B cells, the autoreactive B cells. So we're able to show that we can target and specifically deplete that subset of B cells, but not touch the normal B cells.
Very, very cool. So the biggest question of the day, what's next for this? Where's your next step going to be?
Well, we got to. The hope is, right, that we can translate it. So we'll got to test it in great detail in preclinical models, and then the big question is, like, how can we translate it effectively, right? There is a lot that I think needs to be figured out. I think this is always a process, but the hope is that 10 years from now, we might be at a place where some therapy in that space could become available for our patients.
Wow, that's very cool. 10 years from now, I'll be reflecting on this and thinking that I was there in the first stage.
So like, Max, where is this?
Exactly. No, I'm optimistic. Well, thank you so much for following our coverage at Room Now. Thank you so much, and congratulations on the plenary session.
Thanks for having me, Mike.
Yep, anytime.